Hi, my name is Mercy Melody Coyote, and today I welcome you again to the UNDP Development Dialogues for the Uganda Country Office. And of course, today we are exploring the UNDP's mandate around building resilience around shocks. And this is one of the things we support countries with across over 170 countries across the globe. And of course, the shocks that we are talking about today range around pandemics, disaster, risk, and all these things. But today we are narrowing it down to the question around HIV and service delivery in Uganda. So many funding cuts have happened, and there's a number of people that are likely or have already been affected. And that is why on my extreme right today, we do have Ida Nakanjako, who is a program officer for health and development at the UNDP. We'll get to hear a lot more from her on what the UNDP is doing. But also we do have Shakira Namwanje, who is Executive Director for Acts 101. Of course, we'll get to hear from her some more around civil society, young people engaging in service delivery around HIV. But of course, at the end of the day, we can have all these conversations, but if the government has no say, then we are having a child's play. That is why we do have Dr. Daniel Yamukama, who is the head of HIV prevention at the Uganda AIDS Commission. And just to start off with, allow me get straight to Ida. Ida, help us understand, what is the UNDP doing in the question around health and service delivery?
Thank you, Mercy. Hi, viewers. As all of you know, that health is both a driver and an outcome of sustainable development. So that is the angle which UNDP uses to reach millions of vulnerable populations in the world. So as UNDP, we reduce vulnerabilities through strengthening systems at national level. And we shall get deeper into that. But briefly, at the country level, we do support health systems. And in this case specifically, we work through the Uganda AIDS Commission and the Office of the President to strengthen the national response. In there, we support the legal environment, human rights. We support HIV financing and sustainability. We also support HIV prevention through work of the HIV vulnerable populations. In a nutshell, that's what we do.
Okay. Thank you very much. At least we have seen some of these things already happen, and we do appreciate the UNDP. Very key to this is a question around the gaps that are happening, the suspension of the funding. My question to Dr. Daniel, who works with the Uganda AIDS Commission, an institution that has got the mandate to address the HIV question in Uganda. What have these funding cuts and suspension, made in terms of impact to the people of Uganda?
Thank you. I would say the HIV response has been impacted most. Traditionally, the HIV response has not been receiving adequate funding. When we conduct our national AIDS spending assessment, we establish that only 13% of the resources spent in the HIV response was going to HIV prevention. That was less than adequate in the first case. And that meant the specific programs for HIV prevention were not up to scale. For example, programs for adolescent girls and young women. If we consider the high burden districts that needed really comprehensive services, we are only able to reach a handful of such. Yet these services are needed across the country. But even the ongoing services, the available services, or the services that were there until the cuts in funding were mainly donor supported and mainly by people. And by that, I want to highlight key programs. The programs to address the needs of adolescent girls and young women. The HIV epidemic in Uganda, when we do our own modes of transmission, see which are the most affected populations, we find adolescent girls and young women contribute to the highest number of new HIV infections. So they should be our highest priority in targeting for prevention. but funding for that population group, which was mainly coming from PEPFAR, has been withdrawn. And we're stuck with adolescent girls and young women. Another key program that was key to our prevention program is the circumcision program. Circumcision, which started in the late 2000s, the early 2000s, we discover when we look at our data at population level and we look at new HIV infections among men. If I look at young and unmarried men, I find that young and unmarried men contribute like 8% of new HIV infections. But of that 8%, more than 7% is among the uncircumcised young man. So circumcision is a key prevention program. And most of it was supported by PEPFAR. And support for that program was withdrawn. I must also highlight that most of our new HIV infections in the country occur in the general population, as opposed to the key populations. So in the general population, one of the key prevention tools, in addition to abstinence and being faithful, is the condom, the use of a condom. In use of a condom requires a commodity, but not just a commodity, but making sure it's accessible at the last mile. So the efforts, the system, the machinery that procured the condom and made sure it's accessible, the free condom, most of the Ugandans need the free condom, made it accessible at the last mile, depended significantly on PEPFAR funding, and funding has been withdrawn. So we, as the prevention program, were in a difficult situation, and we are forced to go back to find innovations on how to fill this gap. But I must admit, it's a big challenge, and we are worried we risk losing the gains we had made in prevention. Around since 2010, we have been progressively reducing the number of new HIV infections. We had reduced them from 97,000 in 2010 to 38,000 in 2023. So we wouldn't be surprised if we see the number of new HIV infections in 2024, 2025 being more than what it is now, 38,000. And that's because most of our key programs have come to a standstill, and as a government, we're making urgent emergency movements and preparations to see how we can fill the gap.
Wow. That is a huge challenge from the government in terms of service delivery. Shakira, I know as someone from the civil society, a young woman, but also working with young people, how has civil society been impacted? But beyond just civil society, how have the communities been impacted?
Thank you very much. So communities have been impacted in the sense that the funding cut was very abrupt. So nobody was prepared. You know, when you plan ahead, when you know something is coming, you find a way to plan ahead for yourself. But the funding cuts came at a time when they were very critically needed, and also it was an abrupt thing that happened. So community was very, very confused. There was a lot of misinformation flying around. Everybody saying what they know. So much information flowing into community, and community having very little access to verifying that information. As civil society, we are the gatekeepers of the community, and most of our funding comes from the Western world, if I might say. So that being cut left so many of us jobless. That is one. Two is that bridge that we have between community and government and all these other researchers, scientists, is us as civil society. So with us not having work or not having the facilities or the finances to reach the communities, kind of like impacted the work that we do and left community confused. We had research studies closing abruptly without participants knowing what is happening, how are they going to be followed up, or what are the next steps for them. We had young girls confused in the sense that we are still allowed to, get services as we've been getting them. We had hospital health workers, some of them resigning because some of them were actually under the PEPFAR funding scheme. And for those people being removed away from the health facilities, so left the young women wondering, are we still going to be accessing services as we know it? And some of them, these facilities were closed for a while, so they would go to the facilities and they were shut down because again it was abrupt and the country was still forging a way forward on how we can go from there. And some of them up to now don't want to go back to the health facilities because they don't feel safe there anymore. I mean, it's no longer the normal that it's no longer the normal that they know. For us to get to the 32,000 that Dr. Dan was talking about from the 90,000 that we had to think outside the box. How do we do things? Not the normal traditional way that we know, but how can we now, as much as we have products, we have treatment and so on in facilities, what are the innovations that we can do to get the services in the hands of the person that actually needs the product or the service? And with that, there were so many innovations that were being funded by PEPFAR, whether it is community engagement, community sensitization, whether it is educating communities about research. These are things that are not necessarily funded by government. So, and that at the end of the day is what brought the people to the health facilities to get the services. We had peer educators at the facilities, mentor mothers that are, educating fellow young people to come for treatment, to, adhere to their medication, learn from each other's experiences. And that is why we were getting the gains that we are getting. And sadly, we stand at a loss right now where we are.
So much in terms of the impact. But then before I return to Dr. Dan in terms of what strategies government has put in place, allow me just have a follow-up question with you. How are the communities coping up now? Because the reality is here. Mm-hmm. At the end of the day, we've got to move on with life. Mm-hmm. How is a coping mechanism?
The funny thing about community is if those things are not there, they don't come.
Okay.
That's the reality. If at the end of the day, the things that were pushing them to come to facilities, somehow the way we human beings are made, you will be sick and know you're sick, but somehow you will refuse to go.
So where are they going to?
So some are staying home and not seeking treatment. That's the truth. Some are, as we are forging a way of new normal, some are looking for referrals where best can I now get my treatment from? Some are seeking or reaching out to the civil society organization, but many have closed. Some, as I said, there's no funding. So sometimes as civil society, we act as a bridge. If there's a challenge with the facility where you're getting your services from, you reach out to the civil society organizations and they'll refer you to maybe another facility. In terms of key populations, they feel that safety net is no longer there. So for me to come to where I am compromised, I might just stay away from the facility, which is not a good thing, obviously. But even young people, they don't feel, the young women want to go to facilities where they can talk to their peers. Now that peer thing being scrapped off, that alone is also affected, because when you think about going to the facility and maybe meeting your auntie and they're the ones you're going to talk about HIV prevention, it doesn't seem too cool for you to do that, and they will choose to opt out of the service.
Dr. Daniel, you've clearly had it. Some are going back home even when they know they are sick. They're not seeking the treatment. And I'm sure the government of Uganda will not love to see its citizens die. What strategies does the government, or specifically does the Uganda AIDS Commission, have in place to help alleviate these challenges?
So thank you. I think we cannot deny the importance and the role of civil society in our national HIV response. The government services in their nature are a bit standardized, and they lack that flexibility of giving personalized care to the people in need. And often they don't reach those who are most likely going to be left behind. So civil society comes in to fill that space, to offer personalized services, and to look out for those who are likely going to be left behind, maybe because they are far from the health facility. So the loss of civil society funding is inevitably going to cause a dent in our response. Ordinarily, we would propose the best practice is that the government offers funding to civil society to continue playing that role. This is called social contracting. And unfortunately, there is not yet any legal framework to provide for government to come in and fill this gap, which would be appropriate. But as government, we're currently discussing a sustainability framework. By the time of the funding cuts, the conversation had started and it had not matured. And there are key elements of the sustainability framework that we're already starting to operationalize. One of them is that the government inevitably must increase funding to meet the immediate needs. But that funding is mainly going to treatment and care needs. Not so much of it is coming in to fill the prevention gaps. Secondly, but the good thing is that treatment is prevention itself. Secondly, was maximizing on efficiency gains. We were looking at our program, the way of programming, how can we implement the program in a most efficient way? So one strategy that we have rolled out to increase efficiency is the integration of services at all health facilities. So we're trying to minimize, because when the HIV response started, and by necessity, it was a vertical program. Appropriately, at that time when the HIV epidemic started, people living with HIV were highly stigmatized. They could not come. They were sick. They were emaciated. HIV caused wasting and wasting away. So when they came and lined up together with others, they were prone to stigmatization and humanization. So it was appropriate that we start parallel clinics, which were safe spaces for HIV patients. But we believe we have reached a time where people coming for HIV services, for their drug refills and checkups can sit in the same line and be served by the same doctor who is serving pregnant women or people with hypertension, so that we minimize the need for additional space, additional health workers. We hope when we make those efficiency gains, we shall make savings so that some of the resources can go to meet the unmet need. So right now, the immediate government initiative is to scale up integration of HIV care and treatment and prevention alongside other services. The other main innovation the government is implementing is strengthen mainstreaming. There are so many opportunities in all sectors to increase the chances of passing on prevention messages or prevention services without waiting for the health services alone. So mainstreaming means that every sector, every institutions plans for the prevention needs of their people. Do they need pre-exposure prophylaxis? Do they need condoms? And institutions are being encouraged and trained on how they can strengthen that mainstreaming so that the prevention needs of staff in a workplace can be met by the institution without waiting for the government to come and provide leadership. So we are trying to build capacity to roll out the mainstreaming guidelines and to encourage institutions to mainstream. Institutions of government have already been instructed to allocate part of their budget, the budget they used for other items, but they can use part of that budget to meet the prevention needs of their staff and some of their clients. So we believe as we integrate and we mainstream and we innovate on other sources of funding, we should be able to meet the funding gap, but it will be a tall order and it will take time, and inevitably it will have consequences which we're scared we'll be seeing in a year or 2 years' time.
So talking about sustainability, what government is trying to lay around strategies to alleviate the challenge that we have in place? I'm sure civil society should be also having some strategies to continue with the services that you have been offering. What services do you have? Or in case you don't have any strategies yet, what strategies would you recommend for civil society to carry on with, supporting the people? Because at the end of the day, for any governance structure to prevail or to have, successful impact, both government and civil society, need to pull resources and hands together to do something.
So one of the things that we are doing as civil society, I will tell you, is to keep the doctor Yeah, Mukamas in check. We have to continue carrying the voice of the people, even without pay. We have, as civil society, we have worked for no pay before, and we know we're at a time whereby it is required of us. It's not right, but it's required of us. So we are not stepping down our role because of the new normal that we are in. We have to continue the fight because, again, we have to continue to remember who we are doing this for, which is the communities that we represent. If I put my hat down, then that means the young women that are counting on me to make sure their voices are heard at this table will be losing out. So we are continuing the fight to hold our governments accountable, but also to bring the voices of those communities that we represent at the table. For example, as much as the government is looking at how best can we, with innovations to see that treatment continues, services continue, the voices of the communities represent, like the young women saying, that is not how we want our services to be delivered to us. And if you put them like that, it won't work for us. So it's for us to continue bringing those voices at the tables where they are really, really patent and speak for the communities that we represent, but also continue the education of community, the sensitization, the awareness raising of, what is happening, what services we have, where they are, what referrals are available, but also continue the conversation about new innovations in terms of HIV prevention. The basket that we have is not enough, and some of the products we have are really quite expensive. And to continue those conversations, even with the developers of these products, to say, at the prices where you're bringing, the prices at which you're bringing these products cannot work for our communities. So who are you making these products for? Can your prices come down? So we have a lot of work cut out for us as civil society, and I will assure you, we are not backing down.
That should be the spirit. We are not backing down. But you see, at the end of the day, with all these funding cuts and suspension, while the majority population is being affected, there's a group of people that are really in a very vulnerable and sorry state. The most affected persons, the sex workers and people in those spaces. Dr. Daniel, how are we putting around systems or strategies to support these people? Because you see, at the end of the day, we either may lose them or we may have them infecting more people. How are we trying to work around curbing down the situation to help the most affected people, persons?
No, thank you. I think in our Ugandan context, when we look at our epidemic and who is contributing the bulk share of new HIV infections, idea that everybody's prevention needs should be met. But we are not such a rich country to reach everybody with whatever they need. So we try to rationalize. And in our rationalization, we try to target where it hurts most. And specifically among the key populations you talk about, we find that there are sex workers. There are quite many now. Initially, we had estimated the population size to be around 150,000, but that is like in 2019. But we expect them to have grown in number. And the HIV prevalence among sex workers is high. It's at 3%. So they can actually cause a problem because they can transmit HIV significantly. So we believe that with the available services, with the change in attitudes, over time, we have done good work to change the attitudes and policies to support service delivery for sex workers. That a sex worker can walk into a meeting room and identify as a sex worker. That is a reality now in Uganda. That a sex worker can walk in a hospital and identify as a sex worker and they still will be served with dignity. That is a reality in most of the health facilities in Uganda. And that's an achievement that we have made over time. We do not believe that with the withdrawal of funding, that achievement we shall lose. We are still hopeful. We are yet to monitor. We're still hopeful that our people, in spite of their variety, they can still access the same services. Because if you look at our key populations program, most of it was being implemented in the government public health facilities. So we still believe that these people will be able to work in public health facilities and access the service. But that said, a significant proportion of our people still face challenges in these facilities, and they are being served at specially set aside service centers, drop-in centers initiated by civil society, and unfortunately support for those has been lost. So we expect a loss, inevitably, in gains, in prevention in HIV among the key vulnerable populations. And of course, that also transmits, because the key populations interact closely with the general population. It will impact on our prevention effort. Whether we attain our 2030 targets, it will depend on how soon we come in, how soon we identify the gap, and we fill it, and engage civil society through social contracting to provide the service they are providing to back up the government service. And that's where we are. But in Uganda's context, the other vulnerable populations, including the adolescent girls and young women, I have already told you we lost funding, but we are trying to create within the available resources. Is it through religious institutions? Is it through schools? Right now, we're working on a sexuality education framework to strengthen health education and HIV education and life skill education in school setting. It was not previously taken seriously, but we realized the urgency that there is an opportunity there that we intend to exploit to make sure we save the adolescent girl and young women. But in spite of all what I've said, the shortage in interventions, the reach and the variety of interventions is really reduced. We expect to see a negative outcome, significant, because of the cuts, in spite of mitigation efforts going on.
All this cutting, fine cuts, suspension aside, I'm sure the young people would want to now hear from us. Now that the drop-in centers have been closed, or most of them have been paralyzed, now that there's not so much services even in the hospitals, where do we go to right now? It would be very important for us in this conversation to state, where can I go? Do I go to a health center 3, health center 4? What services can I obtain from there? I'm sure you are in the most appropriate place to.
Yes, of course.
Yeah.
Uganda, we pride ourselves in being a major and non-discriminatory country. We are averagely accommodative. The people who will stigmatize their neighbor because he's a sex worker, they are not very many. They are there, but they are not the majority. So we believe with the initiative to integrate the services. We are training our health workers from health center 2 to health center 3 to integrate all our essential services, including integrating key population services.
So are you trying to mean that I can walk into a health center 2 or 3 and still receive the services?
Absolutely. That is our intention.
Whether
it works out very well as our plan is, it is yet to be seen.
To what level do we have these health facilities? Because I don't know to what level a health center for. Is it in a sub-county? Is it in a village? Help us understand. So by the time we are walking around as young people, we know in my village, I can go to a health center 4, 3, or 2. I don't know. Yes.
Of course, that remains a challenge. Because if you look at services, like pre-exposure prophylaxis.
That is PrEP for information. Yes.
A key services that was needed by young people, a key services that was required, convenient for these key populations. It was accessible at least health center 4. Health center 4s are at the county level. They are not within reach of most people. Innovations take these services closer to the people. Outreaches, drop-in centers, we have lost funding. And honestly, I do not see the way the government service delivery is structured, filling those gaps. But we are saying within the available services, we are going to strengthen those services, create service-friendly corners within the available services, train our health workers where we had a key population-friendly service provider in a safe corner within the facility. No, we cannot sustain that. We are going to train the regular midwife, the regular clinician to be key population friendly, to be youth friendly, to be adolescent girl and young friendly, and we integrate all these services. I must admit, it will take time to arrive there. And as it takes time, we are bound to see a loss in our gains. It will be inevitable. And I must say, we cannot dismiss the consequence of the abrupt cut in HIV funding from one government partner.
Regardless, we'll survive. Shakira, before we leave, PrEP, PEP, very common words being used. What is the difference between PrEP and PEP? And who gets to take PrEP or who gets to take PEP? And I'm assuming there's so many young people out there that don't know. What's the difference between these?
So PEP is post-exposure prophylaxis. Post means after you have been exposed. So PEP is for after you have been exposed. You take it, you go to a health facility. They have to first do an HIV test after you have been exposed. That means you've had sex with someone, you don't know their HIV status. You have been raped or defiled. You have had an accident. Your blood has mixed up with people's blood who you obviously don't know their HIV status. You are having sex with someone and the condom burst, or etc. Really. So after you have been exposed, you go to the facility. They do an HIV test. If you're HIV negative, because it's for people who are HIV negative, they do a test. So if they confirm that you're HIV negative, they start you on PEP, which you take for a period of 21 days. After the 21 days, you go back to the facility. They do another HIV test. If you're negative, you continue with your life. And now PrEP is pre-exposure. That is before you have been exposed. So before you have been exposed, that means if you are in a relationship with multiple partners, if you are in the business of sex work, if you are a person who is living in a population where there is a high HIV prevalence. So there are different if you feel like you are at risk, if PrEP is for people who feel like they are at risk of HIV infection, and that you take before you are exposed, and you take it's a daily. Right now, as a country, we have the daily oral PrEP, which you take every day. I must say we've had innovations that are trying to talk about oral PrEP on demand. It's not yet within our country, but I know for men they're trying because it's different for men and women. But there's innovations around on demand oral PrEP. But there's also in research still where they're talking about working on a monthly oral PrEP pill, which you'll take for a period of 1 month. For as of right now, what is in the facilities is the daily oral pill. So again, for PrEP, which is pre-exposure, like I said, we have that oral pill, yes. In the country, we do have the Depirin vaginal ring, which is also a PrEP product.
What does that one do?
So the Depirin vaginal ring, again, it's before you are exposed. You go to a health facility. They give you a vaginal ring, and the vaginal ring is for women because we're the ones who have vaginas. They give you a vaginal ring which you insert in your in your vagina. It sits at the entrance of your cervix and releases the drug called the Depirin vaginal ring, and helps to prevent you from getting infection or from getting infected with HIV that is through sex, that is vaginal sex, obviously. So it works for a period of 1 month or 21 or 28 days. And after that, you go back to the facility. They give you another ring. Again, for PrEP, we do have the cabotegravir injection, which is the long-acting injection, which is given to an individual every 2 months. Again, we have that in the country, and you receive an injection every 2 months. So you go for an injection, after 2 months, you go back for another injection. And it's all for people who are HIV negative, but you are at risk of getting infected. Yeah.
Oh, there's just so much to preempt from this conversation. But before we go, Ida is here. What is the hope from the UNDP for us? It could be beyond just the planning, but also, coordination. Who are you bringing around the table to support with alleviating this challenge?
Well, as the UN, as a whole of the UN system, we believe in leaving no one behind. So that is why we focus on the system. We do not offer services as the UN or as UNDP, but we strengthen systems broadly. And so as UNDP, with the funding cuts, we are supporting Uganda AIDS Commission and the response to review the policy, the HIV policy. And we believe with the so many changes in the HIV response, the policy will take care of the so many different changes and strengthen the response. We have also been in the conversations of developing the new national HIV strategic plan. We have provided technical support and we are participating in that. Previously, all the NSPs we have been developing have had PEPFAR funding largely. And now we are at a point where we have to look beyond the development partners' support and focus on government support, the national systems. Like Dan said, when we look at for example, the ministries, the MDAs, ministries, departments, and agencies, what do they bring on table? And we have had the contribution of government support previously of the 0.1%, where all MDAs contribute a certain amount of money to the response. So now more than ever before, as the development partners, we have to look at this contribution from MDAs. What does it do? Are they guided? What are the results from this contribution of government? So we have to provide technical support on how that money is used, but also track it, track the input versus the results. So broadly, those are our major support avenues. He talked about the HIV sustainability roadmap that is ongoing. We bring our technical support to that and guide government. Focus on your systems. How much are you willing to put on table to cover the gaps? And really, in this integration roadmap that he was talking about, where you bring all services into one system, this has been our cry over the years. Because you would go to any ordinary clinic in a health facility and find an HIV clinic, a diabetic clinic, a hypertensive clinic. So now we are saying put everything together, and government has started on that, and we are clapping our hands. So we must dig in there to know how government plans to do it. Of course, there are challenges. There are going to be lots of challenges, but it's the way to go. Bring all services together. It is more sustainable. Even when we get support in future, of course, things will stabilize as we go. But if all the services are together, you can easily know the challenges, the gaps, so that you complement what government is doing. So as UNDP, really we are looking at that, strengthen systems in terms of financing, but also looking at what innovations government is bringing on table to close the gaps, to ensure that even where the infections occur most are not left behind or don't drop off. We are very keen on drop-offs, lost to follow-ups. We have had civil society here talking about some young people not going back to facilities. We want to support them. How do we interest these young people to seek services? We want to rally behind civil society and so that they don't lose the morale or even the momentum that they have been working with to complement government services. We want to continue with the government plans that they've had. For example, the CHOOS. If the community health workers that government has been talking about for so long, if we have lost peers who have been largely supported by development partners like PEPFAR, how do we ensure that we don't lose the CHOO system that Ministry of Health has been developing? And we have a community framework that Ministry of Health developed previously. So that strategy, how do we ensure that it is operationalized in this context where we have had where we are seeing cuts in donor funds. So really, there is so much to track the HIV response with, considering the drive towards 2030 and reducing new infections, that the UN and largely the development partners are looking at, so that we don't lose track of the UNAIDS targets of 2030. Thank you.
If you've not understood anything much from this conversation, just take along with you integration. The government and development partners are building capacity of these health workers to be able to respond to all your various needs. Period. That is it that I've taken from this conversation. Thank you for following up with us. Thank you for listening. Thank you, Ida, Shakira, and Dr. Daniel here. And of course, to you all who are wanting to learn to listen, keep listening, but also keep learning new innovations that are coming up. Bye.